Did you guys know what happens when there are injury to your peripheral nerve? For example is radial nerve. Injury to radial nerve are a relatively common complication after fracture at humeral shaft. This injury to the nerve can stop signals to and from the brain, causing the muscles not to work properly and a loss of feelings in the injured area. With a nerve injury, the brain may need to re-educate. Why we need to re-educate? Because the cortical representation of the hand gets disorganized, diminished, or may disappear after nerve injury, putting the hand function at danger. However, the plasticity of the brain, which is the ability to respond to changes through peripheral influence, allows a great capacity for brain functional reorganization to happen even at adult stage. Therefore, after the nerve has recovered, sensory re-education may be needed to improve the feelings to the hands or finger. It is aimed at refining cortical receptive fields with higher sensory resolution, help maintain or restore the distorted cortical hand representation after the nerve injury, and also improving processing in the sensory network at the higher order cortical level, facilitating interpretation of the distorted hand map.
Next, we move on to the administration procedure. In administering sensory re-education technique, we use Talent sensory re-education protocol, which consists of two parts: early phase localization and late phase discrimination. For the early phase, it consists of re-education of moving touch, constant touch or pressure, and touch localization. Moving touch is to re-educate the directionality of movement perceptions of the patient, while constant touch or pressure is the ability to feel touch stimulus that is constant or pressured. And lastly, touch localization is the ability to identify locations that are being touched without looking. For this early phase, the therapist has to stroke the client's palm, which is on the affected part, starting from proximal to distal strokes. This can be done by using either the therapist's finger or the eraser at the backside of the pencil. The use of the hand grid outline is to observe on which part of the hand that the sensory are impaired. This phase can be done 4 times a day and 5 minutes for each time.
Saya akan sentuh tangan puan macam ni. Nanti puan boleh bagi tahu saya puan ada rasa sentuhan itu ataupun tidak. Dan lagi baik kalau puan bagi tahu saya dari mana ke mana saya sentuh. Boleh ya? Boleh. Okay, kita start. Sekarang puan ada rasa ke? Ada. Boleh tunjukkan kat saya dekat mana ke mana. Okey. Sekarang ada rasa ke? Ada. Boleh tunjukkan dari mana ke mana. Okey. Sekarang saya teruskan untuk constant pressure. Saya akan sentuh puan macam ni. Dan puan boleh beritahu saya ada rasa ataupun tidak. Ada rasa ke? Ada. Ada rasa ke? Ada. Boleh tunjukkan dekat mana saya sentuh? Okay.
It is important to note that the grid on the client's hand is only drawn for learning and video purposes. In real-life situation, the therapist doesn't have to draw the grids on the client's hand, as there are hand grids outlined that are prepared for this intervention. It is also to be noted that the unaffected part of the client's hand has to be taped in order to prevent the adjacent unaffected part to aid in stimulus detection of the injured part of the hand. For example, these are the areas of nerve that innervate the palm of the hand. So in case the client had median nerve palsy, the therapist has to assess sensory re-education only to the area that is affected or impaired, which is the median nerve area. While the other two areas, which are considered as the adjacent unaffected part, the ulnar and radial nerve area, has to be taped to prevent them from assisting in stimulus detection of the injured part of the hand.
Moving on to the grading technique of sensory re-education. In early phase localization, the touch will be repeated a few times. First with the eyes open and then with the eyes closed until they can feel and they can know where and what type of touch they are feeling. The touch can include moving touch, constant touch, pressure and touch localization. Then work on a few areas first until they are sure that they can localize the touch correctly.
For the late phase, it is only initiated when moving and constant touch at the early phase earlier are perceived at the fingertips with good localization. This late phase can be conducted usually 6 to 8 months after nerve repair at the wrist with the goal of tactile nosis recovery.
So puan, saya akan bagi puan objek. Ini objek pertama. Cuba puan rasa. Okey. Sekarang objek kedua. Boleh puan bagi tahu saya objek mana lagi besar? Objek satu. Okey puan, sekarang saya akan letak dua benda sebelah kanan dan sebelah kiri. Okay, cuba puan rasa dan beritahu saya mana satu lebih basah. Ini lebih basah. Okay, puan, saya akan bagi puan beberapa objek. Ini objek pertama. Cuba puan rasa. Sekarang boleh puan bagi tahu saya ciri-ciri objek itu. Dia berbentuk bulat.
Puan, sekarang ni saya akan letakkan beberapa objek atas tangan Puan dan saya nak Puan kenal pasti objek-objek tersebut, okey? Ini objek pertama. Cuba Puan rasa dan beritahu saya objek apa.
Sudu.
While for grading of late phase discrimination, first technique, it will use a different shape of wooden block to discriminate between large and small objects. After shape is mastered, ask the patient to differentiate texture rough to smooth texture from wooden surface blocks. The surface can include surface of sandpaper, velvet, felt, velcro hook and loop, hard tip foam, and many others. Then, continue to discriminate the shape of objects using various types of wooden blocks of shape. Lastly, use common household items or objects that relate to the patient's occupation or job.
Now, let's look at the evidence-based study about sensory re-education that has been done in several studies. Firstly, there is one study from Al-Balawi et al. 2020 about patients with carpal tunnel syndrome who received sensory re-education. The result from this study conclude that the sensory threshold of the affected hand of the patients have significantly improved. Next, study from Antonopoulos et al. 2019 have concluded that patients with nerve injury and repair who had sensory learning have better loconosia at 1.5 and 3 years after the injury compared to those who did not. Latest study from Lidstrom et al. 2018 conclude that a sensory relearning program that started immediately after surgery for median or ulnar nerve injury resulted in significantly better sensory recovery compared with traditional rehabilitation. Next, study from Satyawali et al. 2021 conclude that sensation of patients with wrist drop who undergo sensory re-education has significantly improved. Patient symptoms like stiffness, tingling, numbness, and inability to use the hand were significantly decreased in post-test compared to pre-test. Therefore, based on the evidence that have been explained, this sensory re-education has been tested for patients with carpal tunnel syndrome, nerve injury, and wrist drop, and has shown significant improvement on sensory function of affected limb or hand.